You guys ready? Perfect. All right, mic is working, yes. So good morning, everybody. I really am very happy to welcome you to our Multiple Sclerosis R&D Day here today in New York. Thank you very much for everybody here in the room for being with us at Times Square, basically. And also thank you for everybody online for listening to the webcast. Happy to have you all here. So we will take the next approximately 2 hours to walk you through our multiple sclerosis program, and we will also have 2 wonderful guest speakers here with us today, which I will, who I will introduce in a couple of seconds. So, not moving, as always. First slide, once again. Well, okay, the next slide is anyhow the forward-looking statements. You all notice we are NASDAQ listed. Please consider those. Yeah, now it's moving. So let me start with a quick introduction of our speakers today. So I'm really happy that we have today here in the room, and she will be speaking live in a little bit, Dr. Francesca Montarolo from the University of Turin. She came in from Italy just for us here today to speak a little bit about Nurr1 and tell you more about this interesting neuroprotective target. And then later on the call, we will also have Dr. Amit from University of Pennsylvania, who probably many of you know from a NFL paper published last year. He will speak about NFL, disability, and also Epstein-Barr virus. And then, of course, we have the Immunic team here. You see them all on the left side here. We have the full management power in the room today. Speaking will be our CEO, Daniel, our CSO, Hella, in green, our CMO, Andreas, and then also our CEO and President, Jason Tardio, who just joined us. How long is it now? 2 months ago. Right, so first live event today for Jason. No pressure. Good. So here's the agenda. As I said, approximately 2 hours. Daniel will kick off the presentation shortly. And then we walk through the mode of action, Nurr1, and then also all our clinical trials ongoing. I forgot Jason, I'm so sorry. Of course, we have the commercial opportunity first, so you will see some new information and slides in the beginning. But you don't want to listen to me, you want to listen to the others, so I hand over to Daniel to kick this off.
Thank you, Jessica. And maybe it's not me you want to hear today, but more the details on the programs. And I'm very excited to be here today and have you here in person. I hope you enjoy the meeting and you get some also interesting and relevant new information about multiple sclerosis, and also put that into the context of the commercial environment, competitive positioning, some news on mode of action, and specifically, I think, the unmet medical need in the area of multiple sclerosis. But let me kick it off with our pipeline. So at Immunic, we have 3 programs in development, and we have 2 clinical stage programs. I will make that a bit higher here. 2 clinical stage programs ongoing. And today, but we want to really focus on IMU-838, Vidofludimus calcium, which is in development in phase 3 in relapsing MS and also in phase 2 in progressive MS. We also have shown that the drug has an effect in ulcerative colitis, where we reported data on maintenance, 1-year treatment with UC. But today it's all about multiple sclerosis because it can fill it to our meeting easily and even more. But before I hand over to my colleagues, I want to talk about maybe the most important thing from my point of view, which is more or less the elephant in the room if it comes to the unmet medical need. Still today, after 30 years of having treatments for multiple sclerosis, we still have a problem. And the problem is we need to slow down and prevent disability worsening. And if you ask patients, I think the key point is patients want to maintain their independence. That means we, as companies, we as biotech and pharma companies, we need to deliver treatments which are exactly targeting that unmet need, helping patients to maintain their independence as long as possible. That means for us, we need to focus on slowing down worsening of disability. And this is much more complex than we initially thought. There are more things involved. There are more things we need to pay attention to. And my colleagues and our external speakers today will talk about targets, will talk about the relevance of slowing down and preventing disability worsening. And to underline that, we also asked the patients. So we asked the patients, what is the unmet, how do you feel, and what comes to your mind if you think about disease? And what is really, I think, obvious here is that despite being on treatments, despite being on relapse therapies, including anti-CD20 antibodies and so forth, patients feel that they are progressing on disability, even being on the therapy. So the goal of new MS therapies clearly need to be to focus on neuroprotection and effects to stop progression, which is independent of relapse activity. To also think about safer and better tolerated products, and also to address easy to use aspects for physicians, but also for the patients. And we have, I think, a very promising molecule in hands. Vidofludimus calcium could really be a game changer in the area of multiple sclerosis treatment. It combines two main aspects. One is relapse prevention, but of course, on top of that, neuroprotection. And this was underlined already by a couple of data points we have generated over the years, including very positive phase 2 data from our RMS phase 2 study, the emphasis study, hints of slowing down disability worsening from that study, positive biomarker data from our ongoing CALLIPER PMS study, unique dual mode of action on Nurr1 and DH-ODH, and we will come to that in more detail in a minute. And being a first-in-class Nurr1 activator makes Vidofludimus calcium in this development area a unique molecule. But the second aspect also is important. So Vidofludimus calcium is an easy-to-use product, once daily oral tablet, and also easy initiation, meaning you don't need complex screening procedures and requirements for doctors, so it's easy to handle. And at the end, unique safety and tolerability profile. I think that is something which makes, together with the therapeutic effects, it a unique asset and molecule. Before handing over to Jason to put that into the context of the competitive environment and the medical needs, just an update where we stand with development. So we have completed the very important phase 2 study, the emphasis study, which was not only looking for relapse prevention, but also had a look on disability worsening effects. And Andreas will show you some data from that study, which was performed. And this was the starting point for the further phase 3 development and phase 2 development in progressive MS and relapsing MS. And we initiated the CALLIPER study in PMS, where we expect data readout in April next year already. Very exciting time for the team to come closer to that readout, you can imagine. And the phase 3 studies, ENSURE-1 and ENSURE-2, which are twin studies testing Vidofludimus calcium in relapsing MS. And they are supposed to read out in 2026. And with that, I want to hand over to Jason. Thank you.
So good morning, and thanks to all of you for being here in person, for all of you that have dialed in as well. As Jessica mentioned, my name is Jason Tardio. I'm the President and Chief Operating Officer here at Immunic Therapeutics. I joined the company about 2 months ago, and I was attracted to this company for a variety of reasons. I've spent nearly 15 years of my professional career in the multiple sclerosis space, so I understand intimately the needs of the community. I understand the competitive landscape, and I understand this market. And when I looked at Immunic, and I specifically looked at Vidofludimus calcium, I recognized that there's a huge opportunity here. Huge opportunity, first and foremost, to impact the lives of thousands of individuals living with multiple sclerosis today that don't have treatment options. These are individuals, as Daniel has mentioned, that may be on therapy, that are continuing to accumulate disability. These are individuals with progressive forms of the disease. these are individuals who are not currently on therapy today due to either safety concerns, tolerability concerns, or other. And so as we think about Vidofludimus calcium, we believe that Vidofludimus has the potential to transform the multiple sclerosis market and really be a leader within the oral disease-modifying segment. The profile for this medicine will be unique. It is a first-in-class dual mechanism of action approach designed to address the full spectrum of multiple sclerosis, from the beginning stages of relapsing and inflammatory disease through into the progressive stages where neurodegeneration takes hold. It's a first-in-disease, first-in-class Nurr1 activator, and this will provide direct neuroprotective effects throughout, again, both the relapsing and also progressive forms of the disease. But it's also a highly selective DHODH inhibitor, which is associated with potent anti-inflammatory activity, which we know plays a part in the relapsing forms of multiple sclerosis. We believe Vidofludimus calcium will achieve a best-in-class benefit-risk profile within the oral class of medicines by combining strong efficacy across relapses, across MRI activity, across disability, and balancing that with great safety, great tolerability, and convenience of once daily administration. We don't believe there's going to be any first dose or on-treatment monitoring necessary, which means this will be an easy medicine to start those newly diagnosed patients on, and also a very easy medicine to switch patients, of which about 65% of the market today is in a switch category. And we don't anticipate any safety concerns or black box warnings specific to this respective product. Given this profile, and if approved across the vast indications of multiple sclerosis, we believe peak sales of this product could be upwards of $6 billion. So what are these indications and where would this medicine play? Well, Vidofludimus calcium is currently being studied across all three of the major phenotypes of multiple sclerosis, the first of which is relapsing multiple sclerosis. Within relapsing multiple sclerosis, you have individuals with clinically isolated syndrome, you have individuals with relapsing-remitting multiple sclerosis, and you have individuals with active secondary progressive disease. This is the largest of the three respective indications. It makes up about 75 to 80% of the total market today. And this is where all of the currently approved therapies are playing, roughly 20 or so therapies. But even with those 20 approved therapies, as Daniel mentioned, there continues to be unmet need. Patients are continuing to progress. And furthermore, as you see highlighted here, even with about 900,000 patients diagnosed across the major markets, there's roughly only a little over 500,000 that are treated today. So you have a bulk of patients sitting on the sidelines that are looking for new attractive options with new mechanism that balances, again, great efficacy with a great safety and tolerability profile. We're also studying Vidofludimus calcium in the non-relapsing secondary progressive disease. This represents about 10 to 15% of the total market. And eventually, patients with relapsing disease will progress into the non-relapsing SPMS category. And what makes this category distinct and different from relapsing MS is that the relapse or inflammatory activity has stopped, but you begin to see this slippery slope of disability progression. There are currently no products approved to address non-relapsing secondary progressive multiple sclerosis. And it's a large market of about 175,000 patients diagnosed across the 7 major markets. And the third phenotype or distinct category, if you will, is primary progressive disease. And this is a category in which patients start off right out of the gate with disability worsening without relapses or inflammatory disease. This represents about 10% of the total population. There's only one approved therapy today, that's Ocrevus or ocrelizumab, and there's about 120,000 or so patients, we believe, diagnosed with primary progressive disease across the major markets. MS is also a heterogeneous disease. So the treatment goals are consistent across all of these populations, right? You want to reduce disease activity. You want to delay physical and cognitive disability progression, and you want to maintain a quality of life for individuals living with MS. But the disease itself is heterogeneous, and the patients, not surprisingly, are heterogeneous as well. Patients present with a variety of different symptoms. Patients may present with optic neuritis. They may present with arm or leg weakness. They may present with bladder dysfunction. Patients present with a variety of different MRI presentations. They may have little to no lesion load. They may have high lesion load. They may have active lesions. They may not have active lesions. But what we also know as well is that individuals with multiple sclerosis, like you and I, are distinct and unique to themselves. And when clinicians begin to think about treatment options, there is not a blanket approach to addressing multiple sclerosis. There is not a one-size-fits-all. And clinicians need to take into account a patient's disease course. They need to take into account treatment history. They need to take into account risk tolerance of that prospective patient. And they also need to take into account personal preferences, right? Does a patient prefer to take an oral tablet or pill? Do they prefer to take an infused product? There are uniqueness to each of these respective patients, which requires individuality to a treatment approach. And market research supports that this is still what clinicians are doing today, right? Even though there are a segment of the treating clinician population that prefer to take an aggressive approach early, most clinicians do take a individualistic approach, patient by patient, for the respective treatment options. And given this, there are a multitude of products that can play in this large market. So the multiple sclerosis market today is a $20 billion plus market, a market that we forecast to grow anywhere from 2 to 4% year over year, forecasted out to be upwards of 25 to 30 billion over the next 10 years. And not surprisingly, given the uniqueness of these patients, given the role of all of these disease-modifying therapies play within MS and the unique attributes of all of these respective products, there are multiple products that are blockbusters that coexist within this category. Furthermore, we know that the oral disease-modifying therapy segment is large today, is dominant today, and is going to continue to be large over time. The oral category represents over a third of total prescriptions today, and our market research supports that this is going to remain consistent again over the next 10 years or so. Fully acknowledging that the anti-CD20 class of therapies have done a very good job of penetrating the relapsing segment of the market, again, we still see a bulk of patients choosing and preferring oral routes of administration. And what Daniel has mentioned earlier is that even with 20 plus options, even with the anti-CD20s, there continues to be unmet need for new products to address multiple facets of the disease. Clearly, there's need for products that more effectively address disability accumulation, not only relapsing accumulation worsening, but also PIRA, as we've discussed, progression independent of relapse or inflammatory activity. But there's also need for new medicines that address the progressive forms of the disease, as we've discussed earlier, non-relapsing secondary progressive multiple sclerosis and primary progressive multiple sclerosis. And when we ask in market research treating clinicians what it is that they're looking for, not surprisingly, they tell us that they're looking for new products that address PIRA, that address progressive forms of the disease, but that also balance this with great safety and great tolerability. So what does the ideal agent look like? Well, from an efficacy perspective, the ideal agent would work across the disease continuum to address inflammation, relapses associated with inflammation, to address MRI activity, but to also address relapse-associated worsening of disability and PIRA, this progression independent of relapse activity. So what you see here on this respective slide is a continuum of the disease. The 20 or so products approved today address the lighter blue shaded part of this schematic. This is the relapsing or inflammatory aspect of the disease. They reduce relapses. These products reduce focal MRI activity associated with inflammation. And in doing so, they reduce relapse-associated worsening. But none of the products today address this underlying smoldering neuroinflammatory process called PIRA. And what we know and data supports is that both PIRA and RAW each contribute about 50% independently to disability accumulation from the onset of disease. So what this means is that what's needed in the market is a medicine that, again, addresses both PIRA and addresses both relapse-associated worsening. And with Vidofludimus calcium, we have that product. Again, the neuron activation as a neuroprotective target will serve to address PIRA from the onset of disease, and a highly selective inhibitor of DHODH will have a profound impact on the anti-inflammatory or relapses associated with the disease, and thus impact relapse-associated worsening. But Vidofludimus calcium will also do something that we believe none of the other oral products currently do. All of the current oral disease-modifying therapies come with trade-offs. Some may have strong efficacy, but associated with that efficacy are safety concerns directly specific to malignancies, opportunistic infections, progressive multifocal leukoencephalopathy, and other long-term safety concerns that patients need to take into consideration. There are oral medicines that may have pretty good efficacy, but come with a whole host of tolerability side effects in which patients have a very difficult time on a daily basis taking the medicine and maintaining a quality of life. There are oral medicines that are a bit burdensome to start patients on because they require first dose monitoring, or burdensome during the course of treatment because it requires constant monitoring both on the clinician side and or the patient side. So in a perfect world, you would have an oral disease-modifying therapy that has extreme benefit from an efficacy perspective, that has a profound impact on relapses, has a profound impact on MRI activity, has a profound impact on disability and relapse-associated worsening, but also has an impact on PIRA, this progression independent of relapse activity, and would balance that with an amazing safety profile, again, with no opportunistic infections, no serious safety concerns, balance that with an amazing tolerability profile and a convenience of once-a-day dosing, and balance that with an easy to start, easy to stay on profile. And again, we believe Vidofludimus calcium will deliver this. And when it does deliver this profile, there are a plethora of patient segments that could benefit from this type of medicine. Clearly, newly diagnosed patients would be a sweet spot for a medicine like Vidofludimus calcium. We know early in the disease, while efficacy is of importance, balance to that efficacy, especially for newly diagnosed patient, is a concern around safety and tolerability. And again, with this wonderful efficacy, balance with great safety and tolerability, and convenience of oral once-a-day administration, we believe this is a perfect medicine for newly diagnosed patients. It's also a wonderful medicine for patients switching due to disability progression. As Daniel mentioned, we know this is a large segment of the market. And we believe neuron activation, providing a neuroprotective effect, addressing PIRA associated with the disease, will make this a wonderful opportunity for those patients switching due to continued disability progression. It's also a great opportunity for patients switching due to tolerability or safety concerns. We'll discuss the data today, but the data for safety and tolerability with this medicine is remarkable. It's clearly differentiated in the marketplace, and we believe it will be the go-to for patients looking to switch specific to safety and tolerability. This will also be, Vidofludimus calcium will also be a wonderful option for older patients, especially where immunosuppression is a concern. As patients get older, The immune system itself becomes compromised just with age. And so there is an inherent risk of putting this older patient population on immunosuppressant therapies. The marketplace is looking for a medicine to address these older patients, but also looking for a medicine to begin to de-escalate away from immunosuppressant therapies like the anti-CD20s and switching them to a neuroprotective product. Again, we believe Vidofludimus calcium will be well positioned here. Clear, as I mentioned earlier, across the disease spectrum, about 50% of diagnosed patients are untreated today. 50% of diagnosed patients are untreated today. Why are they untreated? Well, they're untreated for a variety of different reasons, right? But largely due to safety concerns, due to tolerability concerns, certainly in some cases due to the lack of availability of medicine or cost constraints. But these patients are looking for an option, looking for a medicine that's effective and, again, that will fit into their quality of life. And we believe Vidofludimus calcium will be the impetus to push the vast majority of these patients off the sideline and back onto therapy. And then certainly, without a doubt, when Vidofludimus calcium is effective in the progressive forms of the disease, both non-relapsing secondary progressive multiple sclerosis and primary progressive multiple sclerosis, we believe that this will be a key product for both clinicians and patients with this respective forms of the disease. Today, again, as a reminder, there is one product approved for primary progressive multiple sclerosis. There is no product approved for non-relapsing forms of secondary progressive multiple sclerosis. And again, Vidofludimus could fill a huge unmet need here. Another interesting point as we think about the competitive and future competitive landscape, there's been a lot of noise about BTK inhibitors, especially of late. But what's interesting is that Vidofludimus calcium is the only non-BTK inhibitor that's an oral disease-modifying therapy that's currently in development for the full spectrum of multiple sclerosis. That's being developed for both relapsing forms of multiple sclerosis, but also progressive forms of multiple sclerosis. So highlighted here on this slide are the three products, again, in the oral disease-modifying therapy category that are currently in development for both relapsing and progressive forms. Sanofi released data not too long ago specific to tolebrutinib, in which tolebrutinib had successful data in non-relapsing secondary progressive MS, but failed to meet the primary endpoint in relapsing forms of the disease. I can't speak to what Sanofi's future plans are going to be in terms of regulatory discussions related to that product, but I suspect that they're going to have a high hurdle to get a relapsing label with that medicine. All right, so let's assume for a second here that tolebrutinib is taken off the table. That leaves two potential products in the oral disease-modifying category that could be approved for the full spectrum of disease, from early on relapsing inflammatory disease through into progressive, more neurodegenerative aspects of the disease. That'd be fenebrutinib from Roche, in which we'll get some data next year, and the only Nurr1 activator / inhibitor of DHODH, Vidofludimus calcium, in which we'll present further data in the coming months. So in summary, we believe that Vidofludimus calcium is a de-risked near-term opportunity with huge upside potential, upwards of $6 billion if approved across all of these respective indications. There's strong clinical evidence to support that the medicine will work in relapsing forms of multiple sclerosis. The phase 2 emphasis data clearly shows a strong impact on the inflammatory aspects of the disease. And we know that there's a previous medicine that inhibits DHODH that was previously approved. So we believe this medicine is very de-risked in the relapsing forms of the disease. But given the profile of having an inflammatory activity along with neuroprotection, along with balancing great safety and tolerability, we believe that there's upside for this medicine in relapsing forms. We also believe that the medicine could be approved for the progressive forms. And again, non-relapsing SPMS and primary progressive. There's a huge opportunity and a huge unmet need in this respective group of patients. And we believe peak opportunity just for these two could be in the $2 to $4 billion range. So again, thank you for your time today. And with that, I'm going to pass to my colleague, Hella, who's going to talk a little bit about Neur1 and Neur1 as an emerging target for multiple sclerosis. Hella?
Hi, everybody. So in this section, we would like to show you the relevance of Neur1 as an emerging neurodegenerative target. And just to give you an overview, first of all, Vidofludimus calcium really addresses the smoldering neurodegeneration by targeting Neur1. And this is Vidofludimus calcium is a first-in-class Neur1 activator. And this is by targeting the improvement of physical and mental ability of multiple sclerosis patients. So coming to Neur1, by activating Neur1, we have a direct and an indirect effect or neuroprotective effect. So because Neur1 is involved in protecting the relevant neurons from thalamus. So that's a direct effect. And in addition to this, it is known that Neur1 activation leads to the reduction of activation of microglia and astrocytes. And this effect by Neur1 activation is independent from focal inflammation. In addition to the Neur1 activation, we know that that Vidofludimus calcium is a very potent and selective DHODH inhibitor. So it brings another level to this medication. So it selectively, by DHODH inhibition, it selectively targets hyperactive immune cells. And therefore, we see selective anti-inflammatory effects, which reduce then the focal inflammation and MRI lesions and relapses. And then what is so wonderful is that with having a DHODH inhibitor, it inhibits viruses as well. It has antiviral activity. And therefore, we see broad spectrum antiviral effect. And in addition, it prevents the reactivation of Epstein-Barr virus, what is super cool in multiple sclerosis, actually. And with inhibiting the reactivation of Epstein-Barr virus, this could stop the cross-reactive immune response in multiple sclerosis patients. With this, I would like to show that the relevance of Neur1 in the different cell types which are present in the brain. So Neur1 is a nuclear receptor which is involved in neuroprotection, and it is expressed in different cell types, namely in microglia, in astrocytes, and in neurons. So Neur1 is expressed there, and Neur1 activation in microglia and astrocytes prevents the microglia or astrocyte-driven neurotoxicity in the brain. So that's the indirect effect. When it's expressed and activated in neurons, we see that Neur1 activation directly mediates neuronal survival. And the Neur1 activation motor neurons may hold the neurodegeneration and the disability progression. So with this, I would like to introduce Francesca Montarolo. She's a senior postdoc researcher from the Neuroscience Institute Cavalieri Ottolenghi and the University of Torino in Italy. She's a biologist and, to be honest, a leading MS expert for MS and the Neur1 target. So she's an expert in neuroscience, cell biology, and immunology, and she got her Ph.D. in experimental neuroscience from the University of Torino. And she is actually one of the first researchers identifying the relevance of Neur1 in multiple sclerosis. And in addition to this, what is a nice connection is that she works on neurofilament light chain as a biomarker in MS. So happy to have you here.
Thank you. Thank you for the nice presentation. Oh, sorry. Yes, yes. Thank you for the very nice presentation. Thanks for the kind invitation. And okay. Okay. Today, I will present you the neuroprotective and anti-inflammatory role of Neur1 that Neur1 exert, sharing with you the publish scientific paper that we can find. Then I will present you the studies on Nurr1 in multiple sclerosis, sharing with you our human and murine MS results. And in the end, I will discuss about the possibility to target Nurr1 for therapies in multiple sclerosis. The nuclear-related protein 1 that I will call the Nurr1 and can be also called NR4A2 is a transcription factor belonging to the heterogeneous orphan nuclear receptor family of the steroid hormone. Nurr1 share a high degree of homology with the other two members of the family that are NR4A1 and NR4A2. Nurr1 is considered an orphan receptor since its ligand binding domain is composed by hydrophobic amino acid, and thus its ligand binding domain is considered closed. Until now, no endogenous ligand have been found. The main role of Nurr1 was investigated in the central nervous system, since Nurr1 is able to induce survival and development of midbrain dopaminergic neuron by the activation of its target gene, such as the tyrosine hydroxylase, that is a key enzyme in the production of dopamine, and of other transporter molecule related to the dopamine transport that we can have at synaptic level. Thus, the loss of Nurr1 causes a complete dopamine neuron agenesis. For this reason, polymorphisms and mutation in Nurr1 gene resulting in its reduced expression are associated to Parkinson's disease. That is a disease in which we can observe selective degeneration of midbrain dopaminergic neuron. However, Nurr1 exerts also an anti-inflammatory role in immune cell, and as you can find here, Nurr1 is able to block the transcription of the pro-inflammatory NFKB pathway, and thus Nurr1 is anti-inflammatory. Interestingly, its anti-inflammatory role is not only exerted in immune cell, but also in nervous system. In fact, for example, Sayo and colleague demonstrated that Nurr1 is able to block the production of the pro-inflammatory cytokines from microglia and astrocytes, and this mechanism results protective for neuron. Specifically, this mechanism is protective from the inflammatory induced cell death of neuron. But what about specifically Nurr1 in multiple sclerosis? Our research activity started from the consideration that pregnancy is able to impact MS disease activity. In fact, it has been well demonstrated that women with MS experience a reduction of disease activity during pregnancy, specifically during the third trimester of the pregnancy. However, relapses worsen further in the postpartum, returning to higher level than the pregnancy, like this. For this reason, we can consider pregnancy as a transitory physiological condition in which, in general, MS goes into remission, so we have a reduction in the relapse rates. Probably this mechanism is due to the immune tolerance that we can have during pregnancy. We have immune tolerance in pregnancy in order to tolerate the paternal antigens of the fetus. However, the exact mechanism by which pregnancy influences MS is not already fully understood. Starting from this consideration and from an idea of Dr. Bertolotto, some years ago, we performed a gene expression analysis with an old technique that is a macroarray using peripheral blood cell obtained from treatment-naive, relapsing-remitting MS patients and healthy control in pregnant and non-pregnant women. Interestingly, we found that more than 300 genes were differentially expressed between MS and healthy control without pregnancy. Among these 300 genes, we found that 8 of these, among which we have NUR1, completely revert its unbalanced expression during pregnancy, reaching the healthy control value, suggesting its pathogenetic role in MS. Specifically, we found that the gene expression level of NUR1 is downregulated, so reduced in treatment-naive relapsing-remitting MS blood in comparison to healthy control, and that during pregnancy, its unbalanced expression return completely rescue to the healthy control value. Interestingly, we found that among these 8 genes that rescue during pregnancy, we have that 3 of these genes, among which NUR1, SOX2, and TNF-alpha-3, is able to block the pro-inflammatory NF-κB pathway, indicating a loss of breaking signal of inflammation that we can observe in multiple sclerosis. Then we decided to better characterize the expression level of NUR1 with the clinical aspect of the disease. And we are able to demonstrate that patients showing lower level of expression of NUR1 are characteristic of the most aggressive form of the disease, evaluated by an increase of relapse rate and disability score. In addition, with these unpublished our results, we are also able to demonstrate that at diagnosis, patients showing lower level of expression of NUR1, because the expression of NUR1 is an heterogeneous condition, this kind of patient tend to start mainly with an high efficacy disease-modifying treatment need to treat the most aggressive form of the disease. And after 6 years of follow-up, we have that patients showing lower level of expression of NUR1 mainly shift to a high efficacy disease-modifying treatment need to treat the most aggressive form, indicating that NUR1 is characteristic of the most aggressive form of the disease. The expression, we are able to demonstrate that the expression of NUR1 negatively correlates with the presence of the most aggressive form of the disease. Then we decided to enlarge our cohort of patients, and now we are able to demonstrate that the reduction that we observed in NUR1 blood of MS is not only related to female, but we have the same reduction if we evaluate a cohort of treatment-naive relapsing-remitting MS patients in the male population. And that we are able to observe this kind of downregulation if we observed whole blood, but also if we observed only peripheral blood mononuclear cell or only CD4 positive T cell or monocytes. Accordingly, the reduction of NUR1 is in agreement with a previous published paper, suggesting that the reduction of NUR1 is a strong result. Thus, our hypothesis was that NUR1 functionality is altered in MS as a loss of breaking signal during inflammation that in MS can't be stopped. A recent paper also highlighted the presence of NUR1 in human MS brain tissues. even if this first characterization could seem controversial in comparison to our results, because the author reported the expression of NUR1 in human MS brain tissues, and they do not observe any reduction in human brain tissues. However, the author reported that NUR1 expression positively correlate with the neuronal density, and specifically they evaluate the normal appearing gray matter, specifically the motor cortex. These results indicate that regions in which we have a higher expression of NUR1 are present in the region in which we have a major density of neuron, reporting the neuroprotective role of NUR1. Unfortunately, the exact expression of NUR1 inside the MS demyelinating inflammatory lesion was not observed before. And so at the moment, we don't have study exactly about the expression of NUR1 in MS lesion. After that, we decided to better characterize the pathogenetic role of NUR1 in MS. And so we move to the study of the murine MS model represented by the demyelinated inflammatory model represented by the experimental autoimmune encephalomyelitis. And in this way, we are able to demonstrate that activating NUR1 by an agonist produced by Novartis is able to delay the onset of the disease, reduce the axonal loss, reduce demyelination rates, and reduce the activation of the inflammatory infiltrating processing. On the contrary, when we induce the DIE model into a deficient NUR1 model, we are able to observe an anticipation in the onset of the disease and an increase of the inflammatory infiltration processes. Thus, as a first take-home message, we can say that NUR1 expression level is downregulated in the immune cell of relapsing-remitting MS patients compared to healthy control, independently from sex and the compartment of the immune cell that we evaluate. That the lower level of NUR1 expression are present in the most active and aggressive form of the disease, and that the NUR1 activation delay the onset of the MS murine model, while NUR1 deficiency anticipates its onset. Thus, our results strongly support the fact that NUR1 functionality is protective for MS. At this time, we understood the importance in order to use NUR1 as a treatment, so the importance to target NUR1 for therapies. And even if the search for agonist or activator of NUR1 is ongoing, few positive results from scientific literature emerge, probably due to the difficulty in the search for a molecule able to insert inside the ligand binding domain that is closed, and difficult in order to recreate a molecule that is able to, for example, activate NUR1, but not, for example, an NR4A1 and an NR4A3, since these three members show a high degree of homology. So we asked whether among the disease-modifying treatment that we already use to treat MS, some disease-modifying treatment are able to modulate the NUR1 expression. And in this first work, we demonstrated that evaluating this disease-modifying treatment, we didn't observe any modulation in Nurr1 expression. In fact, patients treated with the different track show low level of Nurr1 expression far from the control value. However, in a more recent paper we evaluated a class of drug belonging to the sphingosine 1-phosphate receptor analog, and we are able to identify a modulation in Nurr1 expression. Specifically, we are able to demonstrate that patients treated with the fingolimod, that is a drug belonging to the sphingosine 1-phosphate receptor analog, show this increased level of Nurr1 expression. However, we are not able from this work to demonstrate whether this is a direct effect of the drug or only a treatment response. And then in this recent paper, we demonstrate that another analog of the sphingosine 1-phosphate receptor molecule is able to, such as siponimod, is able to increase the expression of Nurr1 in microglial cell culture, but not, for example, in peripheral blood mononuclear cell. Not significant. We have only an increase in microglial cell culture, not in peripheral blood mononuclear cell. We have these heterogeneous results, but we have the same level of expression in blood, unfortunately. I would like to finish my presentation highlighting the possibility that Vidofludimus calcium and analog molecule have as a possibility to activate Nurr1. And this is due by its molecular structure, able to insert inside the ligand domain, and by the highlighted increase of expression of the Nurr1 target gene. Thank you all for your attention.
Francesca, thank you very much for this interesting, insightful presentation. As long as you're on the stage, I would like to give the audience an opportunity to ask questions, to bomb Francesca with everything you ever wanted to know about Nurr1. Yes. Give you the microphone so the people online can hear you as well.
Yes, Rahimi, Piper Sandler. Thank you so much for the wonderful presentation and for the long travel to come be with us here in person. I guess, given the work that you've done, does the whole class of DHOH have this neuroprotection, or is it just Vidofludimus alone that makes it special within that molecule? I guess the question is, do all DHOH compounds have activity on Nurr1, or is, yeah?
We don't know. We don't know because...
oh, they know. Okay. Yeah.
No.
Yes. Hello, 1 second, please.
Yes.
And why? Why? Because it's structurally completely unrelated to other DHODH inhibitors. So Vidofludimus calcium has, in addition to the DHODH inhibition, the activity on targeting Nurr1 and activating Nurr1.
Yes.
One last follow-up.
Yes, and for my experience, I never test it directly. So among our cohort of patients, we never test the expression of Nurr1 from MS patients treated with the DHO drugs. For my experience, my data.
So
among the disease-modifying treatment, we evaluate different disease-modifying treatment, but not this one.
But given your amazing work that you just illustrated on this biology, and you guys have data supporting for this dual mechanism, is there an opportunity that you could be categorized, not within the family of DHOH, that you will be a dual mechanism and the label could reflect that, you know, as we will be getting the INSURE studies, I see. And Daniel nodding his head. That's a huge...
Daniel, up to you.
I think that and maybe adding on what Hella said, this is a chemical feature of the molecule to bind to the right binding site, as Francesca said. So you need to stick into that binding site, and that's something where we know that Vidofludimus is unique from the chemical structure, which makes it different from others. And I believe that it underlines that it's a first-in-class treatment option, really, as a Nurr1 activator.
Okay, we have one more over there, two more. Let's start with the lady.
And sorry, this might not be a question directly related to the presentation that you gave, but just with respect to the hydrophobic binding pocket. So is Vito binding to an allosteric site on that receptor, or have you identified or verified its capacity to bind within those hydrophobic residues?
Yes, I think that the answer is yours.
Binding to site. Binding site. Tension binding.
So Hella said it's binding to site 4. I just repeated.
Yeah.
Okay.
Thank you.
One more here.
Hi, Faisal Khurshid from Leerink. Thank you so much, Dr. Montarolo, for this fascinating presentation. I guess, like, as a multiple sclerosis biologist, could you talk to us a little bit about, like, how do you see this DHODH Nurr1 mechanism compared to something like BTK inhibition in MS from a biology perspective?
I never test it, and I don't know. I think that it's never been tested, so I don't know, because I search in literature for scientific paper about this, but I never try. So I don't know. It should be only speculation, and I don't know.
Oh, one more question back there, Matt.
Dr. Montarolo, if you take a look at how Vito activates Nurr1 and quantify it, I guess the level of activation in your assays and how that compares with what would be necessary in your models to have a disease-modifying effect.
Yes, for these presented results, we evaluate the gene expression level of Nurr1, only the gene expression level of Nurr1. And I hope, so in some cases, we evaluate, for example, the protein expression, but in general, we evaluate the gene expression. So the level of, not exactly the activity level of Nurr1, but the gene expression. So how many transcripts we have inside the cell that can be treated with this drug. Okay.
We will have more data in Hella's presentation following.
Okay.
Okay. Yes, for my point of view, I can answer like this, but
Any more questions for Dr. Montarolo here? Not yet. She's here with us, so can ask more questions later today. Thank you so much, Francesca.
Thank you.
Then we hand it back over to Hella to continue.
Yes, now it's moving. So I will come to your question now, Matt. Because we tested Vidofludimus calcium on targeting Nurr1, and this is actually what you can see, that on the left-hand side, you see that Vidofludimus calcium is a direct binder of Nurr1, that you can see with this ITC measurement. We see that it has a KD of 700 nanomolar in this area. And then we looked as well for the strengths of activation. So we used two different reporter assay systems here. We see a 3-fold activation, and here as well as 3-fold activation. And what is interesting is that we have this already meaningful 1.5-fold activation or 2-fold activation in the range below 100 nanomolar and maybe in the area of 200 to 300 nanomolar. So Vidofludimus calcium is a very selective and potent activator of Nurr1 via binding and activating it. then we had this picture already. So Nurr1 is a nuclear receptor which is involved in neuroprotection. It is expressed in different cells, so in microglia and in astrocytes, and of course in neurons. So meaning that usually when you activate microglia and astrocytes, they can produce pro-inflammatory cytokines and nitrogen oxide and reactive oxygen species, really making, how is Andreas always saying, a neurotoxic soup in the brain. So this means microglia and astrocytes can produce pro-inflammatory environment here. When you activate Nurr1, you have a blockade of pro-inflammatory cytokines, nitrogen oxide, and reactive oxygen species. Nurr1 expression and activation in neurons leads to reduction of oxidative stress, it induces neuronal survival and differentiation, and it activates dopaminergic neurotransmission, and in addition, myelination as well. So Nurr1 activation is believed to be involved in halting neurodegeneration and disability progression. And I will show to you how we investigated the activation of Nurr1 in all these different cell types. So this is what first of all, we wanted to see if we induce primary target genes. For this, we have chosen VMAT and tyrosine hydroxylase, and we're able to show that Vidofludimus calcium is able to dose-dependently induce the expression of VMAT or tyrosine hydroxylase in microglia cells, HMC3 cells. We used astrocytic-like cells, T98G cells. You see again here the dose-dependent induction of the expression of the gene. And we used as well neuronal cells, and you see again dose-dependent induction of this gene, these direct target genes. So next, we looked for the functional readout here. So first of all, we worked on microglia cells, and we're able to show that Nurr1 can prevent the antigen-induced activation of microglia and the subsequent production of inflammatory cytokines in the brain. So here we used Vidofludimus calcium, and in a setting where we used LPS as an induction for stress and pro-inflammatory setting in microglia cells. And then these cells can produce different cytokines like interferon gamma, IL-6, and TNF-alpha. Via activation of Nurr1, you have again a reduction of these cytokines. And this is what you can see exactly here. So we have here the unstimulated control. When you add LPS, you see an induction of the signal for TNF-alpha as well for IL-7, IL-6 and interferon gamma. And when you add Vidofludimus calcium here, just with 100 nanomolar, so it's a really low dose what you need, you see a reduction of the signal for TNF-alpha, IL-6 and interferon gamma. So really reducing the pro-inflammatory setting or area or environment that activated microglia present. Next, we looked for the activation of Nurr1 via Vidofludimus calcium in neurons and the impact on neuronal survival. And here we used, first of all, N2A cells, that is a murine neuronal cell line, and you can induce apoptosis, simulating this neurotoxic environment by adding TNF-alpha and cyclohexamide. So you clearly see here that when you then add Vidofludimus calcium with 1 or 10 micromolar, actually, you see a strong induction of the neuronal survival in these cells after having this pro-apoptotic signal. And we did the same in a different cell line. This is a human cell line here. And the human cell line here, and you see again that we're using 6-OHDA as a neurotoxic signal in these cells. And then at Vidofludimus calcium, you see again enhanced or improved neuronal survival in these cells. And then we looked as well for gene expression because we wanted to know, okay, what's going on here? And clearly you can see BCL2 upregulation, which is a pro-survival gene that is usually counteracting the apoptosis in these cells. So next we did a series, or we did animal models. So it's an EAE model, and we investigated later on the regulation of primary target genes of Nurr1 in these, and then did some stainings in the brain and in the spinal cord as well. So first of all, we were able to show that with 2 different doses, we see decrease of the EAE score here. Then we looked for primary target gene expression within the brain and in the spinal cord of these treated animal models, and looked for tyrosine hydroxylase. Again, it's a primary target gene of Nurr1, and we're able to show that in the brain, for example, we see with the 2 different doses, we see an upregulation of the primary target gene of Nurr1. It was significant for the higher dose with 150 mg per kg, was not significant for the lower dose with 30 mg per kg, but you see the dose-dependent increase here. So it shows a signal already at the low dose with 30 mg per kg. Then we looked as well in spinal cord, we looked for different genes. I just want to display here the SOD1, and that was dose-dependently increased in the spinal cord of these treated animals. In the next step, we looked for BDNF expression, because it's known that BDNF is produced via activation of Nurr1. And BDNF is a brain-derived neurotropic factor, and this plays an important role in neuronal survival and growth, and is a direct target of Nurr1. So in this case, we looked in the blood of the animals, or in the plasma of the animals, and we're able to show that we have a dose-dependent increase of BDNF production in the blood. And then, of course, neurofilament light chain is so important in multiple sclerosis and in the animal testing here. And it is for neurofilament light chain. Actually, it's a neural protein which is associated with neurodegeneration and is a marker for neuroaxonal damage. And this is used in clinical studies as well. So we were interested to see if we can provide, or if we can demonstrate the effect of Vidofludimus calcium reducing neurofilament light chain in these treated animals. And yes, indeed, we were able to do so. So you see a dose-dependent reduction of neurofilament light chain in the plasma of these animals. Last but not least, we were interested in really seeing in the histology if we can improve, for example, the myelination status. Therefore, we looked in the spinal cord of these animals, and we're able to show that we have an improved myelination status after treatment with Vidofludimus calcium. Then we look for microglia activation, and we're able to show that Vidofludimus calcium indeed reduces the activation of microglia in the spinal cord of these animals. And we're able to show that there is indeed a reduction of axonal injury by staining for APP. Again, not dose dependent, because we only looked in the high dose actually. So we see a strong reduction of APP positive area here. We said in the beginning that Vidofludimus calcium is the first-in-class Nurr1 activator. But of course, it's as well a DHODH inhibitor, and this is actually a perfect fit. So DHODH inhibition is really important in hyperactive or high-affinity immune cells, because these cells are specifically dependent on DHODH. These cells have a high metabolic turnover, and for producing cytokines or having the activation or producing antibodies, so the activation, very strong activation, you need tons of RNA. Actually, you need up to 100-fold higher amounts of nucleotides to produce mRNA compared to just having proliferating cells. So therefore, these cells, high affinity cells or hyperactive cells, are super sensitive to DHODH inhibition. For T cells, we see here that it leads to a reduction of the high producing IL-17F and IL-17A cells when you add Vidofludimus calcium. So these cells are very sensitive to DHODH inhibition. And what I would like to show you here, the effect on B cells is actually when you have these super strong stimulation with, in this case, CpG, CD40 ligand, and anti-IL-21. So it's a super strong activation. these cells are then very sensitive to vidofludimus calcium treatment. So we have, in addition to the Nurr1 activation, we have DHODH inhibition, which targets high affinity or high metabolically active T and B cells. And then I mentioned already in the beginning the effect, the antiviral effect here. What is super interesting, especially for multiple sclerosis. So DHODH inhibition per se provides broad spectrum antiviral activity against different pathogenic viruses, and it inhibits EBV replication and reactivation. And this means by targeting the host cell metabolism via DHODH inhibition, Vidofludimus calcium has shown to be active against different RNA and DNA viruses, and this includes strong anti-EBV activity. We were able to show, in addition, that we have the dose-dependent inhibition of Epstein-Barr virus reactivation that was shown in a cell line here, which was stimulated via IgG, and then you have usually normally the reactivation, and if you add Vidofludimus calcium, you have a strong reduction of this reactivation. And this was all done in cell culture, but actually we have human data as well, because by chance we did the emphasis study during the pandemic. So we tested all the patients for, in general, what you do in clinical studies, we tested them for infections, just for any infections. And then in addition, they all had SARS-CoV-2 testing as well. So what was super interesting here was that already with a 10 milligram Vidofludimus, what was really a low dose, you saw that in placebo, there were more infections than in Vidofludimus calcium-treated patients. And when it comes to COVID-19, the effect was even stronger. So placebo patients, 25% of the placebo patients had a COVID-19 infection, whereas only 8.5% of the Vidofludimus calcium-treated patients had an infection. So summarizing this here, we have Nurr1 activation and we have DHODH inhibition. And you see here on the left-hand side with the Nurr1 activation, we have an reduction of the activation of microglia, which are the source of the neurotoxic environment. And we have an improvement of the neurons in this, or of the survival of the neurons in a neurotoxic environment. In addition, with the DHODH inhibition, we target metabolically active immune cells, which are involved in multiple sclerosis, either peripheral or within the brain as well. And with targeting Epstein-Barr virus, we think that reducing the smoldering disease by blocking this constant trigger of immune cells via the inhibition of Epstein EBV reactivation. And to summarize it here, so everything what we learned from the preclinical work is actually that Vidofludimus calcium has a potential to address the unmet medical need in progressive and relapsing MS, because it has the capacity to reduce neurodegeneration directly by improving survival and function of neurons, or indirectly by reducing neurotoxic activity of activated microglia. And then it can reduce the focal inflammation and the relapses by reducing the inflammatory status and number of hyperactive B and T cells. So in addition to this, we think that with Vidofludimus calcium, we can reduce the smoldering disease by blocking the constant trigger of immune cells via the inhibition of the Epstein-Barr virus reactivation. Thank you very much. Other questions? Yes? Jessica?
William.
Hi, thanks. William Wood from B. Riley Securities. I was actually just a couple of quick questions on the preclinical data, specifically on the EAE model and the remyelination. Used the dose at 150 mg per kg, where you started to see statistical significance. How does that relate to the doses that you're currently using, the 30 and the 45 mg in the clinic? But then also in the remyelination status, you see about a 10% increase in remyelination, so 20 to 30. I was curious, what was the length of duration that you actually for those trials, and how long did it take to see that type of increase in remyelination in the brain?
Actually, so we did the analysis after 25 days in this model. We just did, so we didn't do sequential histology staining. We just did it after 25 days. So it was, let's say, the end state of the model at all. And it's really what you can see there is the myelination status. So we did not do it in the beginning. So we cannot say remyelination. It's really a myelination status, I would say. So really protecting it, and potentially, this can be done in the next experiment, potentially seeing an improvement of this. Actually, it should work like this because we have this Nurr1 activation. We showed it on all the other levels. So it should have a positive impact on the remyelination as well. But this needs to be shown. And the other question was about the exposure or the relation with this, between the human doses and the this is actually a tricky question because there's a high species selectivity of the molecule for murine and for human DHODH. So Vidofludimus calcium is the perfect inhibitor of human DHODH, but it's a much weaker inhibitor of the mouse DHODH. So there's a factor of, let me think, of 100 between activity on human, best on human DHODH, and less effective on mouse DHODH. So I need to do the calculation. I can come to you later when I know this. But what we did is when we used the doses with the 30 milligram mg per kg and the 150 mg per kg, actually we really wanted to have a lower dose to see already some effects on the Nurr1 activation without targeting DHODH, because you need quite high levels for DHODH inhibition in the mouse. And it wonderfully showed the activation there already. Oh. Any more questions? Sorry.
Sorry, I'm pushing a little bit because we're behind in time and we have our next expert coming up. So sorry, I don't do this usually, but we need to move on. So I'm trying to go as quickly as possible. We have made wonderful progress in terms of understanding the importance of Nurr1 activation in MS. We have also made a lot of progress in terms of showing what really the effect of Nurr1 activation by Vidofludimus calcium is. I bring you back now onto the clinical program, the ongoing clinical program. So first, I would like to talk about relapsing MS. So taking you very quickly back to our phase 2 trials in relapsing-remitting MS that we did, our emphasis trial. And the major result really was that we show a very large, statistically significant effect in the number of MRI lesions decrease over placebo. So for all of the MRI lesions, for the 30 milligram dose, it's like a 76% reduction in MRI lesions, and it's about a 78% reduction in gadolinium enhancing lesions. So this is meaningful because this points in relapsing MS to focal inflammation. You have less focal inflammation, and focal inflammation is very much correlated to relapse disease, to relapses. And that has been shown over and over again. We have talked about this in the past. In principle, pathophysiology, how I would explain it is that you have these lesions in the brain. Some of them occur in areas that cannot be compensated by other brain areas, and you get a relapse. And therefore, I think this relapse reduction that's what's translating into the phase 3 trials, our ENSURE trials in relapsing MS, into a relapse reduction. And that's important to consider. So we designed the phase 3 program, and you know this, a placebo-controlled 2 studies, ENSURE 1 and 2, twin studies, the same design, absolutely identical. And I will explain this in a second. The primary endpoint is time to first relapse. So it's a relapse-related endpoint. And this is what you have to do to convince regulators that you're active in relapsing MS. And that's, I think, very important, I think, with the last failures of drugs, oral drugs in relapsing disease, that you have to show activity on relapses. So we believe that a placebo-controlled phase 3 program like ours is very much designed to show an effect on relapses. However, I think with everything that you have heard so far, we really think that the distinct advantage of this drug is in disability progression and slowing down disability progression, especially with the Nurr1 activation, which means this is this is the first key secondary endpoint, very important to us. And we have worked with regulators to basically design this program so that we can pool the data from both trials to show a statistically significant effect on disability progression as well. We have always been, I think, the company for the last years that talked about disability as kind of the differentiator for this drug. So this is basically our program. We have a blinded treatment period for up to 72 weeks, 30 milligram vidofludimus calcium versus placebo. And of course, the most important thing that you probably have in your mind is that we have an upcoming interim analysis for our ENSURE programs. So what are we doing and what will you get? So first of all, you have to understand a little bit the sample size calculation and the powering of our phase 3 studies. So the primary endpoint is, for both trials, which have to be independently met, is time to first relapse for up to 72 weeks. So that means these are events that we're counting, yes, because relapse events are important, first relapse events. And for each of the trials, we basically had calculated this at a power of 90% and at a basically 0.025 one-side significance level. So, and this went into the powering of the study. We also have to assume a certain hazard ratio for the treatment effect. So we did a very conservative assessment of the hazard ratio of 0.67 being assumed, so about a third reduction in relapses in the active treatment versus placebo. So I am blinded, we are blinded. So what we can do is we can monitor the overall relapse events in the study on a blinded basis. That's basically a blended rate between placebo and active treatment. And we have to monitor this. And you probably, with the last two readouts, there was always the discussion that they had so few relapse events that it's very hard to show a difference. So it's very important that we have enough relapse events in these trials. And we do monitor this on an ongoing basis. And both our current blinded event rate for first relapses and also for patient recruitment is absolutely within our assumptions that we did pre-trial. So I think we're very happy about this event rate and also about the recruitment of these trials. So what do we do in the interim analysis? In the interim analysis, we had planned to do two things. It was a non-binding futility analysis. So if things really go wrong, they basically, our unblinded IDMC would recommend to us to stop the studies. I think it's standard that there's no specific concern. You do this in clinical trials with an interim analysis, always as the first question. What the real intent was to really say, are we basically on path to have a positive outcome based on an unblinded assessment of relapse rates and hazard ratio in this trial as compared to our pre-trial assumptions. And then our unblinded IDMC would give us a recommendation to either continue as planned, which we think is the most likely outcome, or to recommend to do a little bit increase in recruitment, basically number of patients to be included. So this is something that comes up in fourth quarter. We're already preparing for it. And this is the interim analysis that we will publish. So we do not get any data on hazard ratio, on the performance of the clinical, of the primary outcome of the study and so forth keep that in mind, that this is because we're staying blinded. This is not being communicated to us. We only get these recommendations. So I think for relapsing MS, we continue to see a very unique safety and tolerability profile. We increase our exposure of this drug now to more and more patients. And I think that's very important also because it substantiates the very unique safety and tolerability profile of this drug. So we continue to see this safety that is very similar to placebo control. We have no increase in the rate of infections and infestations. And also importantly, I think to the latest news is that we continue to see no signal in hepatotoxicity, no increase in liver enzymes as compared to placebo. And we have no Hy's Law cases reported today. Hy's Law cases basically how you classify events that have the potential for drug-induced liver injury. So basically for relapsing MS, we believe that we have designed a program, a phase 3 program that really is allowing us with a high probability to have regulatory success. We basically take advantage of the best of the two worlds and with vidofludimus calcium, the neuroprotection via neuron activation and the relapse prevention and the lesion reduction that comes mainly from DHODH inhibition. There is a once daily product. It doesn't have a lot of requirements at startup, node requirements at startup for monitoring, which is different from other drugs. I think this phase 3 program is de-risk, and we will further de-risk it with the interim analysis coming up. And we believe that this gives us a very good chance of getting approval in the relapsing MS space. So this is kind of the part of the relapsing MS, and would like to transition a little bit into the neuroprotection progressive MS. And I would like to do this with basically introducing our next external expert. And I want to highlight this a little bit, why we think vidofludimus calcium has the potential to be effective in progressive MS. So if you look on the right side here, where you have the results of another phase 3 study in secondary progressive MS patients called the EXPAND study for siponimod, an S1P modulator. And the overall SPMS population, there was actually active, non-active in there. You saw some difference in neurofilament comparing active treatment versus placebo. However, if you look into the trial more specifically, you basically see that this decrease in neurofilament comes basically from the populations that have either gadolinium enhancing MRI lesions or have relapses. So this is the active SPMS population that is part of relapsing MS. So as siponimod, did well in the basically relapsing, but in principle, there's almost nothing, no effect on the progressive MS forms, the non-active, the non-relapsing MS forms. Whereas I think we have really shown with our interim analysis that we have throughout all of the subpopulations, non-relapse, secondary, non-active, primary progressive, we have a differentiation in neurofilament. So that makes us very exciting that we are very different from anti-inflammatory drugs as they are approved right now for relapsing disease. So we have I'm absolutely thrilled that we have Dr. Amit here with us online today. He is probably one of the most eminent immunologists in the world. He has a long career. He basically studied medicine at McGill in Montreal, had also done his residency there in neurology, but also been at Harvard and MIT for fellowships. He has now a very unique position because UPenn actually created something that is extremely unique in the MS world. Is they created a position where you're doing research at the same time as being in charge of the MS clinical work. So combining basically groundbreaking research as well as clinical care for MS patients. And that's the position that Dr. Bar-Or has, and that's why I think he has a unique background for this, and has a chance of working on both sides here. So really talking a little bit about what he does and what he's known for in the MS field. One of the things he is known for, because we know from data 2 years ago that Epstein-Barr virus, EBV, is a necessary precondition for developing MS. But as with other autoimmune diseases, yes, the virus causes the inflammation. However, there's probably kind of a dysfunctional immune regulation that then leads to an autoimmune disease. And that's where he has the focus on basically look at that dysfunctional immune regulation. He also works in progressive disease. We know now that it's very different. The pathophysiology behind progressive disease is very different from relapsing disease. And I think with the latest data was very much highlighted that anti-inflammatory drugs work very well in relapsing disease, but you need something very different in order to be effective in progressive disease. And that's something he's working on. And also, I think one of the groundbreaking work about the importance of neurofilament as a marker, as a predictive marker for a disability worsening in the future in progressive MS came through his work, and that was published last year and was really important for the field to really understand that neurofilament is a very good predictive marker for future disability in progressive disease. So we have Amit hopefully online. Yes, I can just stand here and hope that this is the case.
We could stop sharing our slides, and then hopefully we can see Amit.
Can you hear me?
Zoom.
Can you hear me? Can you hear me, Andreas?
Yes, we can hear you very. If we can turn the volume a little bit up, please, here in the room.
Please do. I cannot share at the moment because someone else is sharing. And
okay, so we stop share maybe from here. Exactly.
And I was trying to bring up my video, but that also does not seem to work. As long as you can hear me and I can present, that should be fine.
Yes, we hear you. And
yes, and now you should be able to share your slides. Yeah, here we go.
Good, then I'll.
Great.
Yes. Can hear you and see the slides. That's perfect.
Terrific. Then I'll get started. So apologies, everyone, for not being there with you physically. I wish I could be, but I, in fact, returned late last night from a 2-week trekking in Himalayas, which was a once-in-a-lifetime experience. So forgive me for not joining you. I will be largely reinforcing and extending some of the themes that you had already heard. And I appreciate Andreas's very kind introduction. I was asked to speak to this theme of progressive MS, to highlight the major unmet need that you've heard about, and to talk a little bit about mechanisms and in particular roles of EBV and how we might measure biologically as we try to target this disease therapeutically. And so as an outline, I do want to spend a couple of minutes initially revisiting the spectrum of MS from a clinical standpoint, but with a biological perspective, and to really make the point that I think our clinical definitions of relapsing-remitting, secondary progressive, primary progressive actually very substantially underestimate the extent of underlying progressive disease biology that is largely subclinical, and hence underestimate the very important unmet need of targeting what is otherwise contributing to slow but ongoing demise of CNS, central nervous system tissue. We'll talk a little bit more about mechanisms contributing progressive MS biology in relatively broad brushstrokes, and in particular about some of the emerging roles of Epstein-Barr virus or EBV, and then make again the comment about measuring things that provide us importantly with biological proof of principle that are a very important element of us being able to advance the field as we look to assess therapies targeting disease that is mostly subclinical. And so let's talk a little bit about revisiting the clinical spectrum of MS. This is the typical cartoon that many have presented of a disease that starts with clinically apparent relapses and remissions, and later on develops some progression in between relapses and ultimately non-relapsing progression clinically. That is the RMS-SPMS spectrum, and below we see the PPMS spectrum. individuals tend to present on average 10, 15 years later than the average age of onset of relapsing disease. And here individuals do not seem to have any clinical evidence of relapse and remission, but inexorably from their clinical onset appear to have this non-relapsing progressive disease. And over the years, there's been a lot of discussion as to whether PPMS deserves to be part of the RMS-SPMS spectrum, and in particular, whether the mechanisms contributing to non-relapsing progressive disease as it emerges in SPMS and within PPMS, are they the same or are they different? And we now overall increasingly think that they are similar, if not the same, rather than different. So very importantly, what this gray is meant to represent is the extent of subclinical disease activity. So there's much happening under the surface, and what we see clinically is really only what is above the surface. So much of the relapsing biology in individuals who have relapsing onset MS is subclinical. Relapses occur much more frequently under the surface of detection than what is evident clinically. And the biology underlying this trajectory of progression does not magically start when one day someone transitions from relapsing MS to secondary progressive MS. This concept of transition biologically really is arcane, and we need to understand that the biology of non-relapsing progressive disease extends far earlier along this dashed red line trajectory and starts as early, in fact, as we can appreciate in the disease. May I just ask for confirmation? Can you see my cursor as I move it?
Yes, we see everything and we hear you very well, Amit.
Great, great, thank you. And just as we have this backward trajectory, if you like, of the biological onset of non-relapsing progressive disease within the RMS-SPMS clinical spectrum, we believe that this is also true for primary progressive MS. And what's really interesting is if you look early on when people are identified as having primary progressive MS, especially in younger individuals, you can actually see the subclinical evidence of relapsing biology as captured by the development of new gadolinium-enhancing lesions or new focal T2 lesions. So we actually think, if you consider the difference between these two profiles, actually where the clinical threshold is set, not so much the biology of the diseases, we appreciate that across the full spectrum of MS, there's important contribution of relapsing and non-relapsing progressive biologies, and that these exist not with a transition, but rather with an overlap of decades, and that both are mostly subclinical. And then, of course, there's a lot of clinical heterogeneity for both the relapsing and non-relapsing biology. The major reason for emphasizing this evolution in our considerations here with more of a biological perspective than the clinical perspective is that if we want to target effectively non-relapsing progressive disease, we should not just be thinking of when it manifests clinically, whether in primary progressive or secondary progressive MS trajectories, but that across the spectrum in all of these individuals, the biology is present from very, very early on. And in fact, in our own studies of pediatric onset MS, even in the very first clinical presentation of what then is confirmed to be pediatric onset MS, we already have monikers clinically and through biomarkers of what is a non-relapsing progressive biological process. So quite disconcerting, but I think kind of a wake-up call to understanding the presence of this biology, which we certainly hope that Vidofludimus will be targeting across the spectrum of MS. Now, of course, regulatory agencies still insist on some of this terminology, but I can tell you that the field is advancing. And as a member of the International Clinical Trials Committee in MS, we will be coming out with new diagnostic criteria this year. They'll be referred to probably as the 2024 revised McDonald criteria, building on what currently are used as the 2017 criteria. And the new criteria have a greater emphasis on the biology underlying as opposed to the clinical phenotypes. And we hope that regulatory will move with us over time, as they have done in terms of relapsing biology across the spectrum. And hopefully now the different studies looking at a combination, for instance, of PPMS and SPMS patients clinically, where we think the biology of progressive disease is shared. So that was a little bit of an update in terms of thinking more biologically about the spectrum of MS and highlighting in particular the major underestimated unmet need of non-relapsing progressive disease. Let's transition briefly to broad brushstroke description of mechanism contributing to progressive biology. You've heard about some of these. When we think of a simplified model of the immune system's involvement in MS, we can think of this classical three-compartment model, the periphery separated by barriers from the central nervous system. We think of immune cells getting activated in the periphery, trafficking through a series of interactions involving adhesion, attraction, invasion, and then within the CNS having infiltrated, reactivation, and bringing to bear on the target organ. And indeed, it is these waves of inflammation from the periphery involving peripheral immune cell, perivascular focal inflammation that contributes to the relapse biology. We had thought for years of MS as a T-cell mediated disease. I think we now all appreciate it's not just about T cells. It's about very important interactions between different cell types, including T cells, B cells, and myeloid cells in the periphery that drive these waves of attack and the relapse biology. And then we believe that interactions between immune cells that have infiltrated and set up shop within the CNS and interactions between these cells and brain cells contribute to CNS compartmentalized processes, which can then play out relatively independently of the peripheral processes. And these CNS compartmentalized processes include both inflammation and degeneration and contribute to the non-relapsing progressive aspects of the disease. And this is indeed why treatments that impact primarily peripheral inflammation may be highly effective against relapses, but to date modest in efficacy at best for non-relapsing progressive disease, hence the major unmet need. And in this framework and in these different compartments, we'll elaborate a little later on how Epstein-Barr virus or EBV may be playing an important role. But let's spend a few minutes on this slide, which is a busy slide, but it highlights what have been emerging insights into mechanisms of non-relapsing progressive disease. And these mechanisms can be sort of conceptually divided into inflammatory and degenerative. I'm highlighting first at the bottom, and I won't have time to go into any detail, though we can discuss these, but these are multiple different mechanisms, pathways, and molecules implicated in non-relapsing progressive injury in multiple sclerosis, not necessarily unique to MS, but certainly implicated in MS as well. And they span issues that over time, mitochondrial supply versus demand inadequacies can result in relative states of hypoxia, that the mitochondrial dysfunction of individual brain cells can in turn contribute to an interface between degenerative mechanisms and immune mechanisms, including both innate and adaptive immune responses. And again, I don't have time to go into detail, but very compelling evidence implicating interactions between inflammatory and degenerative mechanisms at the level of mitochondria, but not only them. Then the presence of toxic substances, which are normally cleared by intact glial cells, for example, astrocytes and microglia. These include glutamate, oxygen, nitrogen species, as well as potentially infiltrating molecules and macromolecules from the blood, like thrombin, and that these contribute to toxicity. And while they can be part of the normal tissue turnover, when the normal tissue is injured and unable to clear these, they can accumulate as toxic substances. There can then be ion channel, functional channelopathies, as there's injury to the myelin and redistribution of ion channels across the now bare axon. There is greater effort put into maintaining conduction in the face of the less efficient conduction. And these channelopathies can in turn contribute again to issues of supply and demand mismatch at the level of the mitochondria. As cells are injured, the normal coupling of neural glial support, where neurons support glia and glia support neuron, gets damaged. And this leads to dysfunction in networks, ultimately loss of compensatory mechanisms, and then superimpose all of these different processes on normal aging as well as comorbidities, which are even more common in individuals living with MS than controls, as we now know, especially vascular comorbidities. These all contribute also to ongoing tissue demise. So these may be viewed as largely non-inflammatory, although the emphasis I'd already made is that these non-inflammatory mechanisms interact with inflammatory mechanisms. And certainly we think that among the important drivers of non-relapsing progressive disease are inflammatory mechanisms compartmentalized within the CNS. There have been meningeal immune cell infiltrates described, chronic active lesions at site of prior focal inflammatory lesions that involve inflammatory responses of microglia and astrocytes, among others, as well as infiltrating peripheral immune cells, collectively driving this complex biology. So having talked a little bit, again, in broad brushstrokes about mechanisms of non-relapsing progressive MS biology, let's talk a little bit about emerging roles of EBV. And you've heard about the EBV implication. It had been implicated really for decades in the couple of papers and subsequent follow-on over the last 4 or 5 years that have re-energized the interest, in particular, in this herpes virus, Epstein-Barr virus. And following 2 very high-profile papers, one by Alberto Ascario's group on the neuroepidemiology side of EBV, and the other from Bill Robinson in terms of potential molecular mimicry, we had an opportunity just for a commentary in Nature Medicine as a follow-on again to these seminal papers. And I just want to illustrate a cartoon that we had in this little point of view, which again shows the cascade of immune cells and the peripheral compartment, and then infiltration into the CNS compartment. So again, this anatomic distinction, which is very important, but also some of the immune cells involved, and the implication of EBV through a series of different potential relevant biological interactions centered on EBV infection of memory B cells, which are the main immune cells infected by EBV, and the potential of B cells as central to propagating both relapsing biology, but potentially also CNS compartmentalized biology. And so one can divide the potential contributions of EBV into development of MS, and I think there's now clearly very compelling evidence that while EBV is a common virus, and most humans will be exposed to EBV, meaning that EBV cannot be sufficient to give people MS, it seems as though you cannot develop MS if you don't have EBV. So viewed as necessary yet insufficient for the development of multiple sclerosis. The next question is it also involved in every relapse? And the plausible biology here again would invoke B-cell, T-cell interactions and the issue of insufficient control of EBV, and then the activation of EBV and EBV-infected B cells in driving the responses of relapsing disease. We certainly know that targeting B cells with anti-CD20, selectively depleting B cells, is very effective in limiting relapse. It certainly supports the role of B cells, and if infected, EBV-infected B cells contribute, that could be one of the explanations for the substantial efficacy of selective B cell targeting in relapsing disease. And then the very important notion that EBV may be present within the CNS and driving chronic CNS compartmentalized inflammation that could be very relevant for non-relapsing progressive disease. So therapies, or a therapy that is able to target both peripheral involvement and CNS compartmentalized involvement may prove very important as a single therapy, both for relapsing and non-relapsing progressive disease. And here I'm just sharing a couple of more recent high-profile papers that relate to EBV. This was a very interesting, complicated, but interesting paper that essentially suggested that insufficient control of EBV biology is involved both in the increased risk and potentially increased disease activity in people with established MS. And then a paper involving Heinz Windel's group and Nicholas Schwab that made the point that individuals with multiple sclerosis exhibit a broader EBV-specific T-cell receptor repertoire, meaning, or at least consistent with the view that their T-cell repertoire has been exposed and re-exposed and re-exposed over time to EBV as compared to healthy controls, in keeping with the involvement of EBV as part of the disease process. There's always been a question of, is this merely an epiphenomena of chronic immune dysregulation for other reasons, or is EBV indeed involved in this dysregulation? And more of a sense that the latter is relevant to propagating disease activity in MS. One of the things that this paper was able to do, and I'm showing you a little bit of data from this paper, is making the point and looking at the top of the discovery cohort, and what's very important in biomarker development is a validation cohort, and validating the original observation in the discovery cohort, that if you simply ask about the frequency in terms of particular EBV-specific T-cell receptors on T-cells as part of the repertoire, you can see an increase in the circulation of individuals with MS compared to controls, establishing their presence, if you like, of a broader EBV repertoire, and replicated here again in the validation cohort. And you can then ask the interesting question, as these authors did, is whether or not different treatments may impact this signature, and whether treatment is associated with a decrease in the in this number or frequency of EBV reactive T cells based on their T cell repertoire. And what's interesting here, anything to the left means a decrease in this EBV response marker, anything to the right an increase. And what you can see here is that the anti-CD20 treatments, but also interestingly, the DHODH inhibitor teriflunomide are associated with a decrease in this EBV signature, providing one way of trying to ask whether we can biologically measure the abnormality associated or an abnormality associated with EBV, but also a potential response to treatment for therapies that may target that biology. This slide is really a list of ways that we now think we can measure EBV biology, and it turns out to be important. These represent some older measures, but mostly newer cutting-edge measures. Some of the biology and the ability to measure viral-related responses is something actually we were able with others to leverage our SARS-CoV-2 COVID experience, as has been mentioned already before, and that had many of our labs pivoting to try to study SARS-CoV-2, but in the process developing techniques that allow us to look more specifically at other pathogen-associated immune responses, including EBV-infected B cells and EBV-reactive T cells. And the point I would make here, again, without belaboring too much, is that we think it's important not just to measure one aspect, but the aspects that involve both B cell and T cell responses. So here are a number of complementary and overlapping assays that we now have in our armamentarium that can actually characterize EBV biology and EBV-infected B cells, and others that can detect EBV-specific T cell responses, and not just enumerating them, but also looking at their functional response profiles. As was noted in prior presentations today, it's not just the phenotype, but importantly, the functional response as to whether these cells are more or less pro or anti-inflammatory that is relevant to understanding their role, and also measuring as a biological proof of principle that we've targeted them therapeutically. And in that context, I'm going to transition to the last part of this brief presentation, which again highlights the importance of being able to measure the biologies in vivo, especially when much of the injury that's relevant occurs subclinically. We need additional ways of capturing them. I won't talk about imaging, although there are important emerging imaging measures that may also capture aspects of non-relapsing progressive disease biology, but I will talk briefly about fluid biomarkers, and particularly about neurofilament and glial fibrillary acidic protein, or GFAP, which in particular, as I'll make the point, in combination, may provide us with more specific ways of capturing injury and biological processes of relapsing versus non-relapsing biology, one of the holy grails in our field. So a little bit more about neurofilament light chain. It is a non-specific marker of neuroaxonal injury. You can see here the neuron, its axon, and injury to the neuroaxonal unit results in spillage of NFL, neurofilament light chain, into the CSF and in turn into the blood. We have learned over the years how to measure it now very reliably, not just in the CSF, but also in the blood, a very strong correlation between these measurements. And it has been actually used in terms of increased levels as a marker of injury, not just in the context of MS, but in multiple other CNS diseases, including degenerative diseases and trauma. And of course, there can be also a source from the periphery. So when measuring NFL, it becomes important to adjust for other potential sources of NFL, as well as age, sex, comorbidities that may be associated. But the field is getting an increasingly good handle on how to measure and interpret NFL elevations in the context of MS. But again, not particularly specific. And in fact, much of the abnormal NFL comes from the focal inflammatory injury of relapse biology. The question has been, can we measure beyond that abnormality, abnormalities that are related more to the non-relapsing progressive injury? And indeed, this is a paper that was alluded to before, where one can capture NFL elevations as prognosticators of non-relapsing progressive disease in individuals in whom relapse biology is well controlled. So what this study looks at, which is the combination of the OPERA-1 and OPERA-2 large phase 3 clinical trials of ocrelizumab, anti-CD20, in relapsing multiple sclerosis. Again, keep in mind that although these patients clinically have relapsing disease, we believe, and in fact, this is proof of principle, that non-relapsing progressive disease is present in these individuals biologically under the surface. And what this basically looked at is said, if you take individuals who've been on anti-CD20 for about a year, their disease from a relapsing disease biology standpoint is very well controlled, and now simply dichotomize NFL measured at that time to high versus low, an arbitrary cutoff, and then ask about the cumulative risk of subsequent progression of disability, confirmed disability progression, you get a very clear separation of these two curves, namely the higher level of NFL while on high efficacy therapy against relapsing disease predicts subsequent non-relapsing progressive disability. So NFL in a state of MS that's free of relapsing disease inflammation is a good predictor of future disability risk. But when relapsing biology is present, it's harder to distinguish. And this is where glial fibrillary acidic protein, or GFAP, may come in, because it seems to be, and there's now convergent insight from several different independent studies, making the point that elevations in GFAP may be more specific for non-relapsing progressive biology than progressive biology. And so here's a study, an example of a study that looked at the combination of the two, both GFAP and NFL. This was called the M.B.A Pro-MS study. It's not a large study, but it is sizable enough and certainly in keeping with, again, some convergent studies since then. It's a prospective multi-center observational studies. Patients are followed clinically with either primary progressive or secondary progressive MS, and the goal here was to assess these two biomarkers at the same time. This just gives you a sense of the numbers, 135 with PPMS, 108 with SPMS, followed for approximately 30 months, and looking at an early measurement of NFL and GFAP and how these people did over time. And in fact, those who had high GFAP and low NFL are the ones who clearly could have identified non-relapsing progressive disease. And again, highlighting here as an early example, and what I think is increasingly reinforced, that if we measure both of these molecules, which can be done now readily in serum or plasma, we can actually get a handle on high GFAP, low NFL, high NFL, low GFAP, et cetera, and essentially get a sense of stratifying individuals in terms of what in those individuals is the predominant underlying biology contributing to injury over time. So I hope in this brief overview, I've given you some update in terms of a biological perspective on the spectrum of multiple sclerosis, a little bit on mechanisms of non-relapsing progressive disease, particularly EBV, and how to measure these biologies, both for EBV biology, which is increasingly relevant, we think both for relapsing and non-relapsing progressive disease, but also the fluid biomarkers, GFAP and NFL. And I'll stop here and delighted to take any questions if we have time. Thank you.
Thank you very much, Amit, for this wonderful presentation. And thank you for being with us in this, under your personal circumstances and being able to be here. Any questions from the audience?
I'm coming over.
Just a second, Amit. We will give a microphone to the questioner.
Yeah. Hi. Thank you, Dr. Barrow. This is Faisal from Leerink. I wanted to ask about NFL specifically. I know you've published some nice analysis on NFL's correlation with disability outcomes in PPMS. Could you talk to us a little bit about the strength of evidence for NFL correlating with brain volume, kind of coming at that, considering that it's the primary endpoint of the phase 2 CALLIPER study? Thank you.
Yeah, thank you. So from a sort of face validity standpoint, you certainly would expect there to be a correlation between a measure of brain injury by soluble fluid biomarker like NFL and ultimately what translates into tissue loss and atrophy over time. Of course, atrophy is something that requires larger numbers of individuals and longer term follow-up. I think it'll be very interesting to look in particular, I think, at the combination of GFAP and NFL in the context of the volumetric measurements. As you know, there's global brain volume loss that can be assessed, but also regional volume parameters, including, for instance, thalamic injury. And the thalamic injury may be one of the more sensitive ones for non-relapsing progressive disease. The thalamus is, of course, a relay station, if you like, for fibers coming in and coming out, and its injury is likely to reflect the combination of focal inflammatory disease, but also more diffuse non-relapsing progressive injury. So I would predict that ultimately there will be such a correlation, but we may need larger numbers. And I do think that it's not just going to be NFL, it's going to be the combination of NFL and GFAP, and perhaps a couple of other newly emerging assessments or measures that might contribute to discriminating progressive versus relapsing biologies.
Sorry, the microphone. Yeah, thank you. There was one question here. Was it yes? No? No? Where was it? Ah, William, sorry.
It's okay. William Wood from B. Riley Securities again. Sort of two questions here. The first one on biomarkers. Given that the NFL is much more or can be blurred between there's some feedback on my end. That NFL can be blurred by acute lesions, sort of that the increase of the lesion can lead to NFL production. At least in the prognosis or diagnosis of a patient, how predictive are we there yet with using NFL as a predictor, or do we really need to include the GFAP also to sort of get the idea of a second biomarker in case we're right at the flare up or post flare up of a lesion, and then have a second one?
Yeah, so that absolutely to the point, the focal inflammatory injury of relapse biology really contributes to a big peak, if you like, of abnormally elevated NFL, and that can mask entirely the much lower magnitude of injury from non-relapsing progressive disease. But keep in mind, of course, that lower magnitude injury is happening all the time, day in, day out, over decades. And so the area under the curve of that subtle but ongoing injury is a very important one. And you're absolutely right that in the presence of focal inflammatory disease, it's going to be difficult, if not impossible, to use NFL alone as a prognosticator of non-relapsing progressive disease. So either you're dealing with a context that I showed in that slide where relapsing disease biology is very well controlled with some high efficacy therapy, and then you can reasonably interpret additional elevation of NFL as being sourced from non-relapsing progressive disease, and it will predict non-relapsing progressive disease in the future. Or I think what we'll be doing more and more is not using NFL alone in most MS contexts, but using it in tandem in combination with GFAP and maybe a couple of additional biomarkers. But for those, we still need larger data sets and the capacity to look at how they may or may not predict non-relapsing progressive disease. We're also, as I suggested, pushing the envelope a bit in terms of imaging measures such as slowly evolving lesions or paramagnetic rim lesions, which we believe capture some aspect of non-relapsing progressive disease. And studies now are incorporating both the fluid biomarkers and the imaging markers. Essentially, all MS studies now are doing that, and we're looking forward to data that will allow us to correlate between the fluid markers and these potentially more non-relapsing biology-specific imaging measures and see how they perform.
Appreciate that. And then one more kind of more on the diagnosis and the criteria. Specifically, you mentioned the McDonald 2024, 2023, or whatever it was called. Over time, the annual relapse rates have been coming down, and with the 2024 McDonald, you suggested that it might even be moving towards biology. I mean, essentially, is there going to get to a point when the annual relapse rate is so small that the trials just get longer and longer? I mean, how should we think about current and past trials with these current revisions going less severe patients as well as younger patients and relying more and more on the biology in terms of lesion development as well as annual relapse?
Yeah, excellent question. So there's no doubt that we've seen a shift over the years in the behavior of the control, particularly placebo-controlled groups, with decreasing relapse rates, and that has hurt several development programs. I do think that the move towards more biological definition, which really is based on the recognition that there's a great deal that happens subclinically. How can we capture that more sensitively and more specifically when it comes to distinguishing focal inflammatory relapse biology from non-relapse progressive biology? As we get better and better at doing that, we're going to be in a position, not just from a diagnostic standpoint, but very importantly, as you suggested, prognostication and monitoring in clinical trials, enriching for clinical trials for individuals who have the biology of interest, whether it's the relapsing or particularly the non-relapsing disease. There are multiple reasons why people may get worse gradually over time, as I alluded to. Some are MS related, some are comorbidity and aging related. And of course, we want to be able to capture that biologically and understand what is happening under the surface so we can enrich for more informative trials with the biology of interest.
Hi, Mike DeFiore, Evercore ISI. Thank you for such a great presentation, Dr. Barrow. Just curious to kind of see a big picture question. Historically, when you think about oral medications, oral MS medications, they're kind of grouped in like a middle efficacy bucket before patients historically move on to high efficacy drugs like the CD20s. But early in the presentation, Immunic presented some nice data that, or rationale that Vidofludimus calcium could possibly use after anti-CD20 failures. Kind of just curious to see what you think about why that may make sense biologically. Is it the fact that, as you just presented a couple slides ago, that certain patients have an enormous spike in NfLs, and since Vidofludimus calcium lessens that, is that a reason why a Vito could be used after anti-CD20? Just trying to, any thoughts would be helpful. Thank you.
I think there are at least a couple of questions embedded into what you just raised. So one of them is that historically there had been this sense that, you know, the injectables are modestly effective, the orals are moderately effective, the biologics, including the antibodies infused or injected, are higher efficacy. Yes, there are of course differences in PK and PD when you administer through different routes, and you know, whether sub-Q IV or orally, but it really is a matter of mechanism of action. I think that you know, it so happens that our oral therapies position themselves between modest to moderate, and our anti-CD20s or anti-CD52 and natalizumab, anti-VLA4, higher efficacy. I don't think there's anything magical about it being IV sub-Q versus oral that defines necessarily the efficacy moving forward, but that has been sort of the experience. And I think we should be open-minded about recognizing that this binning is sort of a bit of an artifact of history, not necessarily a biologically meaningful binning. I think that the prospect of Vidofludimus to have a dual mechanism of action, where it may be moderately, if not moderate to high efficacy on relapsing disease, in addition to the very important aspect of targeting non-relapsing progressive disease through the mechanisms that have been elaborated on so elegantly, that to me is a potentially very exciting prospect of having a single agent do both. If Vidofludimus had zero effect on relapsing disease, but had an important effect on non-relapsing progressive disease, that would be in and of itself a major winner. So I kind of take any impact on relapsing disease as bonus. Otherwise, we'd be looking at combination therapies. You know, impacting NFL, of course, you're not impacting yesterday's NFL. You're decreasing new injury and impacting tomorrow's NFL. So once NFL is elevated, that's something's already happened, right? So when we talk about a treatment decreasing NFL, really what it's doing is it's preventing subsequent increase of NFL.
Thank you. Any more pressing questions for Dr. Bauer? Looking around here? No. So thank you very much, Amit, for being with us here today and a great presentation. I hand it back over to Andreas.
Amit, thank you very much. And I know you have to leave the session here, but thank you for being available in this situation. Wonderful.
Pleasure.
Thank you.
Thanks, folks, and sorry to jump off. Take care.
All right. Very good. We have no more time left, so which is great, because everything I wanted to show you is probably reiteration of a message that we had a wonderful, wonderful interim analysis of the CALLIPER trial in primary progressive and non-active secondary progressive last year that made us very hopeful for the final readout in April 2025. So I have a few slides and I will try to skip as quickly as possible so that we're getting to a Q&A and stay in time here. So we talk about, of course, all of this. You had seen wonderful data that we have in neurofilament in our phase 2 study. This was actually kind of one of the things that made us think that there's a second mechanism of action, was that we saw very low disability worsening data in the first 2 years of open label treatment with vidofludimus calcium. Okay. And you have to trust me now, but we had, and this is compared to other drugs that are basically measuring the confirmed disability worsening amount in 2 years of treatment with active treatment. And we have really shown that our rate of 5.5% or 5.6, I hope I get this right without seeing the slides, over 2 years is very low, and it's very competitive as compared to other treatments that are available already in relapsing and MS. So I don't think it's the right. This looks good, but it's not what I wanted to quickly go through. So I think, and now of course this is 5.8. You see, I should do my homework better. So that's what I just explained. If you allow me to kind of use go forward here again. I think we fully completed enrollment of the CALLIPER study last year. You've seen that neurofilament, we believe, is predictive. We have seen that they're very much in line with, for example, the data in ocrelizumab with neurofilament at around 12% difference between active treatment and placebo in primary progressive studies, so that we actually had a very similar decrease in neurofilament for the active treatment. We had done this interim analysis. We had shown you a statistically significant effect on neurofilament after 24 weeks of treatment. We actually also had published the GFAP results, coming back to what Amit just said, that this is important, that we had seen a very encouraging signal in GFAP as well. We published that at the time of the interim analysis. We had seen that this decrease in neurofilament actually was consistent in all of the subtypes of progressive MS, but even more importantly, because Amit just said that neurofilament, you always have to be concerned about the background of lesions or relapses contributing to your neurofilament. But if you take basically non-active PMS, that's basically without relapses, or non-active MRI, meaning no MRI lesions to be seen, we still get a very sizable difference between active treatment and placebo. And I think similar to what Amit said, of course, if you have lesions, they contribute, of course, to neurofilament. But even if you take out, for example, lesions, you still have a very sizable difference between active treatment and placebo. And that's very important from the interim analysis of vidofludimus. And to the point that here Amit made, so if you take out, if you only look at the non-active SPMS patients, for example, for this siponimod study, if you have a purely anti-inflammatory mechanism like an S1P modulator, you basically don't see that difference, or you don't see that advantage in neurofilament that we had seen in this population in the vidofludimus study. So we're very happy about the interim analysis results. We believe that it shows really that vidofludimus calcium has these neuroprotective properties that we are talking about today in the preclinical section in terms of the Nurr1 activation and its effects that it has. And we're looking forward to next year's data. And besides, there was a question about brain atrophy. I think it's very important that we see a good trend, a good effect, a medically important effect on confirmed disability worsening as well. And that's our key secondary outcome there in the CALLIPER trial as well. So takeaway for progressive, I think I said it all. I think the progressive MS study CALLIPER gives us the chance, similar to what Dr. Bar-Or said, to look at the effect of vidofludimus calcium on MS disease in the absence of MRI lesions and on relapsing disease. And that's very important because it really shows that the Nurr1 activation matters and the neuroprotective effect matter. You saw a press release that we did very recently last week about supporting an investigator trial in post-COVID syndrome. I think I wanted to really maybe make a few remarks about this because we're basically treating this as a fatigue study. Post-COVID, one of the major symptoms is fatigue. And I will go quickly to that study. In post-COVID, they have actually now several large studies that really show over and over again that the post-COVID fatigue is related to EBV reactivation, which was an interesting, I think, piece of information for us. So if you look, for example, here on this study, when you look at EBV antibodies that are circulating in your body, these are just meaning you have seen EBV before. There's no difference of patients that have basically with or without, this is always with or without fatigue here, plus LC, minus LC. However, if you look at the DNA, so that means if EBV reactivates, you see fresh DNA, EBV DNA in, for example, saliva or blood. In this case, it's saliva. You actually see a lot of difference. So reactivation of EBV seems to cause fatigue in post-COVID syndrome. Since EBV plays such a great role in MS as well, I think we are measuring in all of our trials EBV reactivations, DNA and saliva. We're also measuring fatigue. And that's why we believe that this study in PCS could reiterate, gives us additional supportive information that blocking EBV reactivation with Vidofludimus calcium contributes to less fatigue. In this case, it's PCS fatigue, but in our studies, we hope to show the same in MS fatigue, which is very important as well. And we actually had done, in our COVID trial, we had done a questionnaire after patient had recovered from COVID that said, do you have fatigue? Not knowing at that time where we ended up in terms of fatigue, but it was the most common symptom. And we actually shown that those patients who received 14 days of treatment of COVID-19 disease, they had a much less basically percentage of fatigue than those patients who had received placebo. This was only 14 days of treatment. This was acute disease, very different settings. There's no post-COVID syndrome. But I think we have some sort of understanding that EBV and reactivation and strong fatigue, probably both in PCS and MS, are related to each other. So that's why we supported this study and hope that. So this is the short summary of the study. This investigator study. We contribute only study medication, and was basically the end. And I was hoping to get to a summary for Daniel. Thank you.
Yeah, thank you, Andreas. And it's now up to me to summarize a little bit what we have heard today. And you may feel that we are excited. So we squeezed in a lot of information here in that meeting. I hope you share this excitement somehow. Having a drug which really can address the elephant in the room of targeting, preventing, slowing down, disability worsening, giving patients more independence for a longer period of time. And with this dual mode of action, we have I think from a biology and chemistry point of view, a really unique, maybe even a fancy tool in hands, which could change the way we treat multiple sclerosis. And we are confident as a team that we may change that. We have more data coming, and we decided not to put in much more here in this presentation. So there are posters coming at ACTRIMS conference next week, actually. So the posters will be available on our homepage. A lot of different biology information, more detailed analysis. I don't want to add more boring stuff here to the presentation, but it's necessary to link science and the use and the therapeutic benefit of what we're doing. And we believe vidofludimus calcium can be a better medicine for MS. And looking forward on what's coming next, I think we have a lot of things coming up. We spoke about interim analysis, so the next data point is the interim analysis or futility analysis of the ENSURE study in the next quarter. And then I think a very important readout will be in April next year, the CALLIPER phase 2 data, including NFL, GFAP, but also the clinical endpoints like confirmed disability worsening, so that we can have a real picture. What does vidofludimus calcium do on top of the relapse prevention? And then further down the road, we expect the phase 3 data from the ENSURE 1 and ENSURE 2 study and completion of the studies in 2026. Yeah, and this is more or less the final slide of today's presentation. So I hope you understand why this balloon is different from the other ones. It has a lot of properties which differentiate the drug for both indications. For relapsing MS, it's a safe drug, well tolerated, easy to handle. I think gives a lot of benefits for treating physicians and for patients for relapsing MS. And then adding with the Nurr1 activity and this evolving new mode of action, another quite unique feature and a unique spin, which is different from everything else which is in development on research. So we believe that this makes it a very unique potential new medicine for treating multiple sclerosis. And with this, we want to conclude the presentation and happy to take maybe 2-3 questions before going to lunch.
Exactly. I know everybody's hungry, but I want to give all of you the opportunity to ask some questions to the Immunic team. Jason, Hella, Andreas, Daniel. Who was the first hand? I didn't see it.
Great. Thank you so much for the presentation, Daniel. And good job, Andreas, wrapping that up quickly. Just one quick one. I mean, so tolebrutinib, I know, Jason, you talked about it kind of a little bit more from the commercial angle, but I guess, we're going to see that data end of next week. I'm just curious, what will you be looking for in that data set, and how do you think that might impact or change your thinking on vidofludimus if it does at all?
I think for the patients, it's good if it does something. And we are looking forward to understanding exactly what does tolebrutinib do. I think, as Jason said, it will be challenging for RMS. Maybe it's a good tool for progressive MS. We will see what's coming out there. I think there's more to do, more to handle. I don't want to comment too much on unpublished data. We need to wait a little bit what comes up at ACTRIMS on the details there. I think still there are some concerns regarding potential liver effects of all the BTK. So it's still in the discussion, I think.
Yes.
Yes, Piper Sandler. 2 quick questions. I think that interim futility analysis will be a time point where many investors are going to be paying attention to. So as of right now, is it fair to say on a blinded basis, it seems there will be no sample size adjustments needed? Like, I think just any comment you could give us, because obviously it would catch people by surprise, right? If they say, no, you got to add more patients. So that's question 1, and then I have a follow-up.
Yes, I think I'm blinded. We are blinded as a company. So all we can do is look whether we have enough relapse events in this trial. Yes, and after the evobrutinib studies, there were a lot of discussion about relapse rates and can we be successful. We plan for a very different relapse rate as what you have seen in evobrutinib, and we actually see this blended relapse rate in the study. So in that respect, we always felt we have done the right thing, first of all, in terms of country selection, patient selection, but also in terms of using placebo control, which gets you more relapse events into the studies and allows you to be successful. And that, I think, it's the only thing I can do at the moment, because I cannot understand, I have no idea about the hazard ratio, and I will not be even after the interim analysis. This is only something that's seen by our unblinded. But in terms of the events, yes, we're seeing the events. We're getting from the number of patients that we have, we get the number of events that we expected. This is very important given basically the last 2 readouts in relapsing MS that both failed for that reason.
Okay. And then the second one is, I think it's going to be commercially really important to educate physicians around this novel dual mechanism. So now that you've been around in publishing data and or presenting data on the Neur1 activity, is there understanding among experts, aside from our true world expert on this topic, that gets it? They're like, oh, it's the dual mechanism Neur1. I understand what Neur1 does. So like, once you're approved, this novelty could drive adoption, or are we at its infancy of awareness of MO?
This is one of the reasons why we have that event here today, to make sure it is communicated, people understand it. Yeah, and if you look back on maybe 5-10 years, it was a totally different understanding of the disease.
Yeah, what I would add to that is the following. And there's always a requirement for market education, right? And disease state awareness. In the case of Vidofludimus calcium, there's a couple of things at play here. First and foremost, we will have to educate on the role of Neur1 activation and why that's important in MS and why it provides neuroprotective benefits, right? Alongside this dual mechanism of a selective inhibition of DHODH, right? So there will be a need to do that. I think there will also be a need to continue to highlight that multiple sclerosis isn't just an inflammatory relapse-specific, relapse worsening related disease, right? And so one thing, as I look at glass half full and optimism, by the way, I mean, we commend Sanofi and we commend all of our competitors for continuing to generate data in areas of high met need. We hope that there's a place for BTK inhibitors. But one of the things as we think about Sanofi and any other BTK player here is they're going to continue to harp this story of progression independence of relapse activity. If there's one thing that the data from last week told us is that there seems to be an indirect link between the potential inflammatory or anti-inflammatory effects of a BTK inhibitor and its potential effect on disability progression, right? So that's going to require a market level education around PIRA, around what this progression independence of relapse means. And then of course, we as Immunic, as we come alongside with our data, we will ride that wave as well to further augment that story alongside the forthcoming CALLIPER data.
Thank you, Jason. One more here.
Thank you, William from William again. I was just actually curious about some of the scenarios you could possibly discuss for the CALLIPER readout, the full data coming. Maybe thinking about the NFL kinetics expected and how those may read through or predict the confidence and level and hitting sort of a stat sig on brain volume, and then also maybe if you know of any correlations of confirmed disease progression and brain volume, if there's any correlations there based on past literature or even your own analysis.
Yeah, I think it's difficult to discuss without knowing the results of the study. So of course, there's something we talk about scenarios, what's coming out there. I think the holistic view is important. So we need to look on all of the different endpoints. And the study is big enough to also show good biomarker data, but also good clinical data and differences. The only point is it's not powered for statistical benefit on the disability worsening, just from the size of the study. So there will clearly the focus will be on numerical benefit on these secondary endpoints. That is, I think, a typical phase 2 question at the end.
In terms of that analysis and sort of evaluating exactly where your efficacy, apart from broadly active everywhere, will you maybe discuss how your data will be, where your trial is actually stratified and how you'll be looking at the individual subpopulations and then the potential to move forward after that?
Yeah.
So the study was stratified between the treatment arms to make sure that the baseline EDSS and the age at baseline is taken into account for the randomization, because I think these are usually two important baseline characteristic of patients that will drive the therapeutic effect or effect size of therapies. And that's just historically, I think what you know. That's why we stratify for them and make sure that those are very well balanced. Baseline EDSS and baseline age are well balanced between the treatment groups. We have not had any specific guidance on the amount of primary progressive and non-relapse or non-active secondary progressive patients in this trial. But what you saw is that we have 2/3 non-active SPMS and 1/3 primary progressive MS in this trial is probably very much related to the amount of progressive MS patients available that are currently looking for new treatments.
And maybe to add one thing, we coming to your question about more sophisticated analysis. One strength of the biomarker analysis we have published last year was that the signal was there in all of the subgroups of indications. So we had a signal in primary progressive, in non-active and active secondary progressive. We always have seen, and these are separated patient groups, we have seen the signal everywhere, which makes me very convinced that this is predictive of future disability outcome. That's what I believe, taking from that, a little bit away from just random data, which you somehow have with biomarkers if you just have a single isolated signal. But here we have 3 independent subsets and also the confirmation from the phase 2 emphasis study.
Okay, just looking to my right side here. Yeah, Matt.
Just a quick question on the interim analysis expected later this year. Will you be getting some detailed safety data beyond sizing of the study and stuff like that you'll be able to share?
Yes. So this IDMC, this unblinded IDMC, actually has ongoing safety assessments during the trial. Yes. So this is, yes. So we do a very repetitive unblinded safety assessment, and there was basically so far they basically came back to us and just said continue as planned. Yes. And so this every IDMC meeting has this on an ongoing basis.
Okay, thank you. I would suggest we close the official part of the presentation now. I guess everybody's hungry. We have a buffet outside. Thank you very much for staying a little bit longer. Also, thank you very much to the online audience for staying with us today. Thank you once again to Francesca and also to Amit for speaking. Thank you to the Immunic team. And yeah, I would say let's close this and please enjoy the lunch outside. Thank you.